Hello to the urologists everywhere and welcome to the electronic urology teaching course. My name is Mohamed Noureldin. I'm one of the urologists in Basingstoke hospitals and I'm an assistant lecturer in urology in Ain Shams University in Egypt. This will be the third talk in the electronic course and it's about the assessment of the male infertility cases, which is a very crucial topic in the clinical life and one of the tables in the FRCS exam. To approach a patient presenting with infertility problem, we should start with the definition of the problem. It is really important to make sure that the patient is meeting the definition of infertility, which means he has failed conception for the last 12 months in spite of regular unprotected intercourse. And the reason for saying that, healthy couple chances to achieve conception in every intercourse is not 100%. Actually, the chances for it is about 25% per month, 76% in 6 months, and 90% after 1 year of regular intercourse. So if the couples passed a year without success at that time, this is considered an infertility problem. Although some clinicians nowadays may start to investigate that at 6 months duration. In the clinic, both partners should be assessed. The female partner should be assessed for any history of previous pregnancy, smoking history, the menstrual cycle, and any gynae or previous obstetrics problems. Then back to the male partner, he should be assessed for any risk factor for infertility as history of undescended testicle, previous months or recent febrile illness that may affect the semen, previous surgery, radiation, or chemotherapy to that area. Sexual history also is a really important factor, which could be the reason, so like a problem in the erection, a problem in the libido, or an ejaculatory problem. One of the important things also is the timing of the intercourse, using of lubricant and using of any contraceptive methods, whether they are aware about that or not. Then to the examination. Check first the secondary sexual character, like the penis and the meatus side. Then look for local examination to check about the testicular size, consistency, fullness of the epididymis, and the presence or absence of the vas bilaterally with the presence of any degree of varicocele. For the semen analysis, the collection having a very few points that need to be aware during the FRCS and even in the clinical examination. So we need at least 2 semen samples. These should be at least 4 weeks apart. Usually we ask for 2 to 7 days of sexual abstinence before the collection. Avoid using lubricant or spermicides before collecting the samples. Once it is collected, it should be placed in a sterile container and it should be delivered to the lab within 1 hour. Ideally, it should be kept warm, like to be wrapped in a shirt or a trousers pocket. We all know the WHO parameters for the semen analysis, and it is a really crucial point that everyone should be know in the clinical life, and it is a fate did end in the exam if it is not known properly. Further investigation would be usually required. For example, hormonal assessment such as the FSH, LH, and testosterone level will be really important usually in case of low sperm count. In cases of isolated low testosterone level, it's recommended to test it again in the early morning to check for the circadian rhythm, and also it's advisable to check for prolactin level. Special investigation may be offered selectively, such as a karyotyping, the microdeletion, and the cystic fibrosis gene, in people who we are supposing them to get more infertility workup and they were supposed to get more to sperm extraction and to go to the IVF process. They should be tested for serology also for viral markers, which will be needed for the sperm banking. The result of the hormone level will usually be an indicator of some of the pathologies that could be happening. We usually look for the FSH level first. If it is high, then we should think about a seminiferous tubule problem or a primary testicular failure. But if it is low, this is where we think about the secondary causes like the hypogonadism or the secondary testicular failure. What about imaging? Imaging is actually really crucial because testicular atrophy and infertility is a risk factor for testicular cancer. So we usually do testicular ultrasounds in these patients to look for any neoplasms. At the end, thanks for your attention. This was the first part of the infertility, which was just the initial assessment of the infertility cases. We'll still have to discuss every condition and how we will go more through this investigation, but I hope that this small refreshment would have made much benefit for you. Feel free to send any question on this email that I'm provided on the screen, and I will answer it once it is possible. I would be also very grateful if you could fill the feedback form, which you could access through the link or by scanning the QR code. Thank you and have a nice day.